the issue of the funding landscape is of a concern for all of us. We've noted again in many of our studies, programs and clinics that have had to close down because of issues of funding. There's a lot of anxiety in our patients because they're not sure what will happen. Many patients have asked me, so what will happen to us? One patient asked me, so I should start saying my goodbyes. And one said, oh, well, it gave me time, at least my children have finished school. So there's a lot of anxiety in patients and communities. And that impacts on their care and on their well-being and on their mental health and on the community at large. For us as Africans, we have to think about what can we do for ourselves, because there's no assurance about funding landscape. We have to think about how do we appropriately fund our HIV programs and in a way that is sustainable, that is safe, and that leads to the best outcomes for our patients. I think it's possible if we look within and restructure our programs so that they're efficiently run and in a way that ensures everybody gets good care.
Surface looks like several different studies. From your perspective, involve all of the studies, what do you think connects everything together?
So what connects all of it is, one, the issue of safer treatments for our patients, and two, the issue of working with an aging population. I think globally we're seeing that more and more people with HIV are older, which is a testament to the success of HIV treatment programs. But as they age, there are other issues that now we need to think about over and beyond the HIV if they're to stay healthy. So I think that those are sort of cross-cutting areas.
Give me a summary of the Sangura study and the findings.
Okay. So the Sangura study is HIV treatment study, or clinical trial as we call it, that's looking at people living with HIV who are older. They're all above the age of 60. And we're looking at testing 2 drug regimens. So HIV treatment traditionally has been about using 3 drug regimens, a combination of 3 drugs in one. And that's what we've used for many, many years. And sort of that has become the accepted construct around how to use HIV treatments. But as time goes on, we're also realizing that fewer medicines are actually better, because each medicine that you put in comes with its own challenges. They have some side effects, perhaps. They may interact with other medicines, hence leading to other, adverse outcomes. So increasingly, people are testing the concept of using 2 drugs as opposed to 3 drugs. This has been done and probably already accepted in many Western countries, but it's not as common in our context. And 2 drug regimens sort of come in different forms. The one that people may be most familiar with is the injections for treatment, which includes 2 drugs rather than 3. But injections are not widely available. They may not be suitable for everyone. So now we're looking at tablets that include just 2 drugs instead of 3 drugs in one. And that's where the Sangura study comes from. So what we did is we enrolled a group or a cohort, what we call a cohort of people living with HIV who are old, as I said, above the age of 60. They were on a 3 drug regimen, and we switched them to a 2 drug regimen. And we are following them up over the next close to 2 years. So at this time point, we're presenting the 6-month results. What have we seen at 6 months? And basically what we've seen at 6 months is they all maintained viral suppression, which means in terms of the HIV treatment, they did pretty well. There are a number of things that we observed about this population, and that was the issue of comorbidities or other diseases that occur alongside HIV. And these are diseases that are important because they really are the ones that lead to most of the mortality or deaths in patients living with HIV. So, for example, a lot of hypertension, a lot of diabetes, high cholesterol, kidney issues, and increasingly we're seeing a lot of cancers as well in this population. So those are things that we're also tracking alongside the actual HIV outcomes.
I'm curious to know your perception around research into treatment of HIV among older adults. Anytime we hear on the international stage or big stages around HIV treatment, they usually focus on pregnant women, newborn, but we rarely talk about older adults. So do you think there is an issue of under-research facing this group, or why do you think we are not making the noise about this group?
So in Africa generally, in the West, I think we've had an older population or people living with HIV. Here, we've traditionally dealt with a younger population. Majority of those getting new HIV infections are younger adults or adults into their 30s and 40s. But the concern of the older population is that we are again seeing some infections in the older population, but also because people are aging with time. We've had HIV programs for more than 20 years now. So someone who started in treatment at the age of 40 is now 60 and growing older. So we recognize that most of our population living with HIV is going to be aging, and we have to think about them. This has traditionally not been studied much in our context, and there are very few cohorts that really tell us about HIV in the older person. The virus is the same, the treatment outcomes are likely to be the same, but the issue is there's so many other conditions that we have to think about, even with the HIV, and we cannot continue to just do things as normal as this population ages.
This group is probably showing us the longer term impact of HIV treatment. And I think you also mentioned it, the fact that we are just looking at getting the first set of older populations on HIV treatment. When you look at it from the lens of all of these studies, especially on this particular group of individuals, what insights can we say about how decades of HIV treatment impact looks like at the moment?
Yeah, I think one of the things we recognize is HIV treatment has been good. It has kept people alive. It has allowed families to thrive and, children to have parents. So HIV treatment has been fantastic. The other big impact of HIV treatment is that it has reduced transmission in the community. Transmission occurs when the people who have high levels of virus in their blood can spread to others. So with HIV treatment, we suppress the virus, and with that, we have fewer transmissions. So that's a fantastic thing. But on the flip side is that many of the drugs we use may also have side effects. So for example, one of the most commonly used drugs in Africa, one of the components of this combination of three drugs is something we call tenofovir in the form called TDF. And that's the most commonly used part of the combination of HIV treatments. It's been a fantastic drug, but we also recognize that it can damage the kidney, and we also recognize that it can also have impact on the bones. And as people are growing older, their bones are inherently weaker. So if you also have a drug that impacts that bone even more, then, we end up with more fractures and other issues that are related to bone. Kidney disease is particularly expensive and difficult to treat, so we really have to be on the watch out for that. And we've had older drugs that led to a lot of increases in cholesterol, for example, and that leads to heart disease, to strokes, and the rest. Many of the current drugs are a little friendlier when it comes to things like cholesterol. But again, we also have issues of weight gain with some of the HIV drugs. And weight gain, again, leads to things like increased cholesterol, increased risk of heart disease, and the rest. So those are things that we have to watch out for. And we have to constantly be thinking about what safer drugs can we bring in that will lead to less complications or lead to less comorbidities arising out of treatment.
When I was reading the posters, and I think especially the one regarding hepatitis B, one of the things that came to my mind was, I think, highlighting the significant number of participants that had prior exposure to hepatitis B.
Yes.
From your insights in the study, how do you think this complicate decisions around using dual therapy?
Yes. So hepatitis B is a virus, and some of the drugs we use for treating HIV also treat hepatitis B. So earlier I mentioned the drug tenofovir, which has been fantastic because it treats both HIV and hepatitis B. So when we go towards dual drug regimens, and all the dual drug regimens do not have tenofovir, and largely because of the issues I talked about, impact on kidney, impact on bone, impact on cholesterol, and the rest. All the drugs do not have tenofovir, which means we have to be concerned about potentially removing a drug in people who may also have hepatitis B. Hepatitis B untreated can lead to, destruction of the liver tissue and potentially liver cancer. So it's an important thing that we have to think about. Most countries in Africa rolled out the hepatitis B vaccine probably about 20 years ago, which means the younger populations are already vaccinated for hepatitis B, and it's not a concern in that population. But the older people did not have opportunity to get vaccinated against hepatitis B, which means there are some who may have hepatitis. In the HIV population, we found that when you use the routine test for hepatitis, about maybe 1 to 2% of our patients will have hepatitis B. When we do more tests that are not necessarily routine, then that proportion may go up to about 5 to 7% or thereabout, which means even when you think about very large populations of HIV patients, 5% becomes a large number. So we have to think about how do we safely transition someone from a 3-drug regimen to a 2-drug regimen without you losing the benefit of hepatitis B treatment as well. And what this means for us is that as we think of these two drug regimens, we have to, one, think about access to hepatitis B testing, and even more importantly, access to hepatitis B vaccination. It's only available in most countries, it's only routinely available in the early childhood vaccination program. But now we need to start thinking about adults' access to hepatitis B vaccines, so that we're not doing good on one hand by removing excess drugs, while some potential harm by not controlling hepatitis B. So it's really just a call to governments around ensuring that some of these vaccinations are also available to adults.
Yeah, I have a policy question, but before I go there, do you have any concerns or surprises regarding comorbidities or treatment outcomes at this early stage of the study?
So I think one of the things we've noted, because this is an aging population, we are seeing a lot of increases in blood pressure, in sugar. That's probably just because of the aging rather than because of the drugs. As time goes on, of course, we're monitoring things like the blood pressure, we monitor the sugar, we monitor the cholesterol, the liver function, the kidney function. We do a lot of monitoring as the study goes on. And that also helps us pick out things that should be concerning with different regimens that we study. Part of all clinical trials is safety. So we really have to think about, are these regimens safe? So that we're not just taking something that seems good from the West, but thinking in our population, is it safe beyond being good for the virus, for viral suppression?
What kind of policy relevant outcomes or insights can you share across these three studies that could be significant for the patient we serve?
Okay, all right. That's a good question. So I think one of the things we've seen across all the studies is that there's a very high rate of comorbidities. And I've mentioned this over and over. We have to be concerned about heart disease. We have to be concerned about strokes. We have to be concerned about kidney disease and the rest, because the risk factors are very highly prevalent in this population. So in terms of policy for HIV programs, it's around being sure that we can monitor and we can put risk reduction strategies so that you're not treating someone for HIV for 20 years, then losing them to a stroke, then losing them to a heart attack or losing them to kidney disease. So we really need to think about, how do we monitor? How do we ensure we reduce risk? The other one, again, particularly for African governments, is around ensuring we have access to safer treatments. We've always had what we call the public health approach to HIV treatment, which means everybody was put on the same treatment. It was easier for procurement, easier for rollout, easier for training of healthcare workers. But as we have different populations, we have to think not just easier, but safer. Because if we roll out what's easy just so that everyone can be treated, then on the other side, you now have to treat the complications. It actually makes the program more expensive, as opposed to if you're able to identify the subgroups that require different treatment and treat them appropriately so that you're not spending money again treating complications. I think that makes the program cheaper than just rolling out one drug for everyone. I think the other thing is, many of the treatments we're testing are things that are already registered in the West. They've been approved and are in routine use for a few years. The reason they were approved and are in routine use is because they were able to test and show that they were safe and better for their populations. We always lag behind. So it's really a call for improving research capacity so that we can have data to inform how we practice in our own context.
Those are really beautiful recommendations. What is next for the various studies, and are they in any way protected from what is happening in the global HIV funding landscape?
So the studies continue. Studies continue thanks to very many different funders and drug companies that donate some of the products that we use in the studies. So the studies continue. But of course, the issue of the funding landscape is of a concern for all of us, because you need to have patients in care for you to be able to do any study in care. So we've noted again in many of our studies, programs and clinics that have had to close down because of issues of funding. There's a lot of anxiety in our patients because they're not sure what will happen. Many patients have asked me, so what will happen to us? One patient asked me, so I should start saying my goodbyes, And one said, oh, well, it gave me time, at least my children have finished school. So there's a lot of anxiety in patients and in communities. And that impacts on their care and on their well-being and on their mental health and on community at large. I think for us as Africans, we have to think about, what can we do for ourselves? Because there's no assurance about funding landscapes. Even if something came back today, we're not sure it will be there next year or 5 years from now. So we have to think about how do we appropriately fund our HIV programs, and how do we fund them in a way that is sustainable, that is safe, so that we're not spending more money treating people, and that leads to the best outcomes for our patients. I think it's possible if we look within and restructure our programs so that they're efficiently run and in a way that ensures everybody gets good care.
What is the impression you can share regarding discussions at the conference around these issues? What is the ambience, and are you optimistic about anything at the moment?
Someone said yesterday that we are pessimistic with hope, but I think the optimism comes from the fact that there are many groups out there that have been working with patients and that are continuing to do this work in spite of the cuts that are there. The general mood from the conference, I think, is one of cautious optimism. It's one of thinking through how do we not lose the gains that we've made over the last 20 or so years? How do we engage patients better so that they're part of their treatment rather than just programs shoved down into communities? And I think that's what makes people a little hopeful. There's a lot of talk about how governments must restructure and must consider how they budget for HIV programs. I don't know about other countries, but in my country, HIV programs are not routinely funded because everything, or almost everything, was donor funded. And there was very little going into these HIV TB programs from government. And now the call was to governments to reconsider how they budget for health, how they finance health, so that they include HIV treatment programs into their budgeting and into their financing programs.
How important was this conference holding in Rwanda to your attendance?
I think one of the things that we have to note is that majority of people living with HIV live in sub-Saharan Africa. So I think it's important that things are taken to where the people are. Holding a conference, a HIV conference in Africa, makes more sense than holding a HIV conference in the global north, because this is where the bulk of the issues are. So I think it also encourages more Africans to attend. I've attended conferences in many other parts of the world where, the representation from Africa is less, yet they are the ones who have to deal with the bulk of the problem. So I think it's important that our conferences such as this are held in the places where the majority who are impacted by HIV live.
What is your biggest take home, and what are the feedbacks you've gotten from people who are sharing these studies insights? Any feedback you can share with me?
I think there's a focus around safer regimens. There's research around, cure research is still going on. There's a lot of work around long-acting regimens. Actually, our group has also presented some other work from what we call the Impala study, which is looking at the injectable regimens. It's work that was led by our colleagues in Uganda. We're doing it in Kenya and in South Africa, and looking at the injection regimens, how patients in our context to do on the injections, and other groups that are really looking at having longer acting regimens. It's maybe ease the burden on healthcare facilities, but also ease the burden on patients, reduce stigma and the rest. So there's a lot of focus on that as well. There's a lot of focus on how best to implement programs in the context of funding cuts. And how to ensure that, we don't lose patients out of care. There have been questions around, and we have less frequent dosing of the current medicines that we use so that the commodities we have last longer. Would that be safe? Does it have an impact on viral suppression? So there's a lot of interesting discussions that are being had. But I think the main thing is how do we maintain the gains we've made in the face of these cuts?
Lenacapavir is very popular at this conference. Are you concerned that the ecosystem is putting a lot of attention on that and not taking to other issues that are still pertinent in the global fight against HIV?
So long-acting regimens are fantastic, I think. And we've heard about prevention and the recent entry of lenacapavir, which is a twice-a-year injection. And I think the way to win HIV is to prevent HIV. Those who are on treatment need to get good care, but we need to stop more people getting on treatment by preventing HIV. So I think that is are an important area of focus. I guess the only concern is that these drugs, even though excellent, are not available to us right now. But there have been a lot of agreements between them, the manufacturers, WHO, different funders.
Thank you very much. The HIV topic is something I love talking about. Did you include any key population in your study?
The representation of key populations amongst the older population is fairly low. So for this particular study, no, we did not have any key population.
Okay, thank you very much.
Sure.
Have a
All
lovely
right.
day.
You too. Thank you so much. All right. Bye bye.